Hi, this is Dr. Sherry Shabowski from Medical Education in Minutes. This is another classic clinical presentation for you. If you like this content, please like and subscribe. Now, let's meet Sandra Corde. Sandra Corde is an 83-year-old healthy female with high blood pressure and cervical stenosis who is enjoying a bath at the end of the day. She lives independently in a large elder care community. She got out of the tub and slipped on the floor. She struck her chin on the edge of the tub. She was stunned and in pain and pushed her medical alert button, which alerted the facility and called an ambulance. The paramedics applied a C-collar and placed her on a backboard and transported her to the hospital. When she arrived at the hospital, she was complaining of neck pain. Her hands have been becoming increasingly clumsy, and both of her arms are numb. She has a burning sensation across her shoulders. She has a past medical history of hypertension and cervical stenosis. Her vital signs are 170 over 90, 95, 20, and she is afebrile. The doctor does a complete physical examination, finding that she does have midline neck tenderness in her cervical spine. She has an abrasion and superficial laceration on her chin. Her exam is also significant for motor weakness. She has 2 over 5 strength in both hands for grip. Her biceps are bilaterally 3 over 5 and her triceps 4 over 5. The rest of her motor exam in her lower extremities is normal. She has decreased sensation in both arms, but the sensation in her legs appears to be intact. Her reflexes are minimal in bilateral upper extremities, but the reflexes are normal in her lower extremities. The doctor sums up what he's learned. He has a hyperextension injury with bilateral numbness and weakness, upper extremities much more than lower extremities, and distal strength is much worse than proximal strength. And he says to himself, I think I know what this is, and we need a CT scan. The patient gets a head and C-spine CT. The head CT is normal, and the CT of the cervical spine shows cervical stenosis at C5, C6 with osteophytes. There's no fracture and normal alignment. The doctor goes back into the speaks to the patient, and he says, your CT scans are normal except for the cervical stenosis that you already knew about. But I believe you have a spinal cord injury. I think what you have is central cord syndrome. This is the most common incomplete spinal cord injury we know of. It often results from a hyperextension injury, particularly in someone older with cervical stenosis or degenerative joint disease. This hyperextension injury results in a bulge in the ligamentum flavum that squeezes the spinal cord against the osteophytes in the already compromised canal. Here we see osteophytes and degenerative joint disease can lead to cervical stenosis at baseline. With hyperextension injury, the ligamentum flavum buckles and further compromises the spinal cord, causing a contusion that manifests in the central cord. The presentation of central cord syndrome is typically motor loss in the arms, which is much greater than the legs. The hands are more affected than the arms because it affects the distal upper extremities more than the proximal upper extremities. It affects flexors more than extenders. Classically, they cannot complete fine motor skills, such as buttoning their shirt. The motor symptoms are greater than the sensory symptoms. Sensory symptoms include decreased pain, temperature, and crude touch. As in the picture, the findings are greatest in the hands, less in the arms, and less in the thoracic region. Typically, the dorsal columns are spared, so vibratory sense, proprioception, and soft touch is typically retained. The cord is divided into gray and white matter. The butterfly pattern is the gray matter in the center and contains the motor and sensory neurons. The axons of motor and sensory neurons run in tracks within the white matter. The corticospinal tract contains the axons of upper motor neurons in the brain. The ventral motor horn contains the lower motor neurons. The lateral spinal thalamic tract contains sensory axons that contain information for pain, temperature, and crude touch. The dorsal columns are sensory tracts that carry information regarding soft touch, vibration, and proprioception. Central cord syndrome can be of varying severities. Since it extends from the center and the injury is typically cervical, ventral motor horn cells are frequently damaged, causing weakness at the level of the injury. But the injury can extend into the lateral cortical spinal tracts, causing upper motor neuron damage to the cervical and thoracic regions. These are closest to the center within the tract. The injury may also manifest by affecting the lateral spinal thalamic sensory tract, which leaves the area less responsive to pain, temperature, and crude touch. The dorsal columns are typically spared, so vibration, fine touch, and proprioception are spared. Sacral sparing is a classic finding with central cord syndrome. If you look at the diagram, you can see that the tracts are labeled C for cervical, T for thoracic, L for lumbar, and S for sacral. And the sacral components are the most peripheral. So that diseases that affect the central cord are more likely to spare the sacral area. Since there is no surgical pathology on CT and the symptoms are getting worse, we will begin with high dose steroids and schedule an emergent MRI. In a situation where you have a high suspicion for central cord syndrome, you can consider high dose methylprednisolone. This needs to be done within 8 hours to have any kind of efficacy. Doses vary. It would typically range between 1,000 and 2,000 milligrams IV. This is not standard of care, but in our patient situation, we're early in the course and only an hour or so has gone by. The patient has had progressive symptoms and no clear bony protrusion that could be surgically removed. We will do an MRI for definitive diagnosis because this is what will answer the question definitively. And we will do a neurosurgical consultation because it is important to have the expertise of your neurosurgeon when dealing with incomplete or complete cord syndromes. The MRI shows osteophytes in the C6 region, cord contusion at C6 with edema in the C6 and C7 region. No physical decompression appears possible. Okay, now let's see how Sandra is doing 2 weeks later. She is at occupational and physical therapy. Fine motor movements of the hands are the most affected by central cord syndrome. Wrist extension returns first, and hopefully, she will ultimately get back her fine motor skills in her fingers. All in all, she feels pretty lucky and glad that the doctor knew so much and treated her so quickly. Hopefully, she will be able to button her shirt soon. Thank you so much for learning with me today. If you like this type of content, I would really appreciate it if you would like and subscribe to my YouTube channel. Full course content is available at www.medicaleducationinminutes.com. The more you know, the better your diagnostic skills will be. See you next time.